Well, thank you for the invitation. I'm going to tell you an update on pomalidomide in combination with bortezomib and dexamethasone for myeloma patients. And obviously, this is a very exciting area where you've seen from previous speakers the benefits of the combination of IMiDs plus proteasome inhibitors and the really unprecedented levels of response that one can achieve in our patients. Now, the chemical modifications for this molecules, as you know, they're really trivial, but the impact on efficacy and toxicity has been quite remarkable. And I think pomalidomide really stands out as one of the most powerful of the IMiDs with recently reported activity both as single agent and in combination. Now, of course, like Sagar, I wanted to show the cascade plot for the activity of pomalidomide before we look at it in combination with bortezomib, which really shows in a heavily pretreated patient population a high degree of anti-myeloma activity. A word of caution, there's a lot of discussion always around risk and overcoming, quote unquote, overcoming high-risk genetic features. And I'm going to say, even abstracts like this have tried to explore the issue. I think the stark reality is that high risk will always remain there. And even for some of the things that we talk about, the risk agnostic, there's going to be opportunities for evolution. At the end of the day, all of this is Darwinian. So one has to be careful with that. And in my opinion, the reality is that for the high-risk patients, we still need to be continuing to look for more intensive, perhaps more effective, longer duration of therapies. And this is an example just looking at pomalidomide plus the dexamethasone versus high-dose dexamethasone. Well, the two main trials that have been presented, one is the one by Dr. Paul Richardson, which he updated at the ASH meeting, where he treated 22 patients who were previously treated. All of the patients had to be treated previously with lenalidomide, most of them refractory to lenalidomide, where he went on to show in 22 patients that he had a 75% overall response rate and 20% very good partial response rate. This was using the biweekly schedule for bortezomib. I'm going to show you the data now from slides I got from Dr. Mikhail of the presentation he did for this phase 1/2 trial of pomalidomide and bortezomib in patients, again, with relapsed and refractory myeloma. And as mentioned, there was somewhat a paucity of data. Of course, Paul has updated his clinical trial now in ASH of 2013. And this was trying to assess the efficacy of the combination, but now using weekly bortezomib. Phase 1 portion of the trial, the pomalidomide at dose level 1, pomalidomide was given at 4 milligrams, bortezomib at 1.0, and dexamethasone at standard doses on days 1, 8, 15, and 22, with a dose level increase of bortezomib to 1.3. Primary endpoint was to determine the MTD of the combination, and the 6 phase 1 patients who were treated at dose level 2, which ended up being used for the phase 2 clinical trial, were also included in the phase 2 trial analysis. And of course, standard response criteria assessment. And so a total of 25 patients were reported in this particular presentation. 9 in the phase 1, 3 of them at dose level 1 and 6 at dose level 2, and then another 16 patients were reported at the phase 2 portion of the clinical trial. For those in the phase 1, the 9, the median age was 63. We determined a third of them were high risk or intermediate risk disease. Median number of regimens was 3, which I think this is going to get interesting as we go on and on with future clinical trials, because I think it's going to make quite a bit of a difference when one looks at second, third versus fifth relapse for our patients, which is now the case for many of the new agents. All patients treated previously with steroids and lenalidomide, and 89% had a previous stem cell transplant. And in this phase 1, 8 out of 9 patients responded, and I think the depth of the response is quite impressive. 5 patients with CR, 2 very good PRs, and 1 partial response. Now, when we take this to the dose level 2, and the median age 66, 31% again high risk status, median prior lines of therapy was 3. 100% of them had received lenalidomide, 75% had a stem cell transplant, and 50% had bortezomib. And the response rate, again, in this group was very high, 94%, with 5 CRs, 4 very good PRs, and 6 partial responses. So this is, of course, intriguing regarding the adverse events. They were consistent with what we would expect with both agents, and nothing new that came out, particularly out of the combination that was different from baseline. And as you can see, is described there with a portion of patients having hematologic toxicity. So Joe went on to conclude that, of course, the MTD was pomalidomide at 4 milligrams, bortezomib at 1.3, and dexamethasone, all of this being used on a weekly schedule. And obviously, this sort of sets the stage for us having used this combination of two in the off-study setting in the patients with relapse and refractory setting, which is also consistent with the data that Paul Richardson has previously presented. Now, Sagar showed this slide yesterday of why is this working so well, and I think it just goes back to normal plasma cell biology. He calls it, as Larry Boyce has said, the Tao of plasma cell biology, and we'd like to explore further ways that IMiDs work so well in combination with proteasome inhibitors. You know, there's a lot of press recently because of the description of the critical role both of cereblon and then Icarus as part of the response to IMiDs, and now we know that's probably not the full story, as in theory you would require an intact proteasome, but we can actually do full proteasome inhibition with this type of combinations, so there must be other contributing explanations to the efficacy of this combination. So one of the fellows in our lab has been looking at the possibility of disruption of this normal plasma cell biology. And he took the cell line OPM2 actually and treated the cell line with 72 hours of lenalidomide treatment, and actually compared this both with the native cell line to one that we could do the SH for cereblon. So downregulating cereblon actually reduces sensitivity of the cell line to the exposure as predicted. But one of the observations was that the cell lines that were treated with lenalidomide accumulated light chain in the endoplasmic reticulum, putatively increasing ER stress and associated apoptosis, again going back to normal plasma cell biology. Now this also resulted, induced XBP1 splicing, and this was only seen in the cereblon positive cells, and as you can see the target and the non-target shows a significant difference between the spliced and the unspliced version of the XBP1. Now if cereblon is overexpressed, this actually makes the cell line sensitive to lenalidomide and causes more of the accumulation of the IgA lambda intracellular concentration. I was showing you only the blots. This has been tested now as well through ELISAs of supernatant of the cells, looking at the secretion of lambda light chain in comparison with intracellular concentration of lambda light chain. So you see the cereblon overexpression versus the vector cell line, and also the immunoglobulin light chain knockdown actually causes lenalidomide resistance. This is again with OPM2. And this is consistent with the whole hypothesis that perhaps by causing disaggregation of accumulation of light chains in the intracellular space, we might be inducing more stress and setting up the stage for proteasomes to be more effective. So to test that hypothesis, one of the things that was done, we looked at OPM2 as well controlled and treated with lenalidomide, bortezomib, and then the combination all shown in the red. But then if we had the pretreatment with lenalidomide, the degree of cell killing was much greater, particularly with earlier administration of lenalidomide, again setting the stage for increased ER stress associated with the intracellular accumulation of the light chains. And also in the non-target, you of course have the accumulation of the cleaved PARP, whereas you don't see that with the SH cereblon OPM2 cell line. So we kind of are intrigued about why this is happening, and potentially this would have some therapeutic implications in the sense that it might make sense to provide IMiDs just slightly before one provides a proteasome inhibitor, which probably doesn't matter for most of the treatments we give, but even for the first treatment, there might be some advantage of early start of lenalidomide. This, of course, needs to be treated clinically. Now, just for closing, I want to show you a picture of lenalidomide, a movie of a lenalidomide treated patient. This is a patient that was really at the end for treatments and came down with multiple lymphadenopathies, and in fact, the radiologist called me, sure this patient had metastatic thyroid cancer. One of those lymph nodes was biopsied, and the lymph node was essentially consistent with infiltration of plasma cells. Can we get the movie? Let's see if it goes. Well, if it doesn't, it's okay. It would just show you that after one cycle of therapy, all of these lymph nodes disappear in a patient, again, who had been extensively pretreated. This patient then went on to get a second autologous transplant, and after this lived a couple of years. So clearly, very effective agent in the setting of relapse and refractory myeloma. So also to counter Sagar jokes, in the case you're thinking I'm becoming a softie and liking IMiDs in combination with proteasome inhibitors, I still have a soft spot in my heart for the combination of CyBorD. Thank you very much.